So welcome everyone to this webinar on the physical health of young people with a mental illness. I would like to begin with an acknowledgement of country and acknowledging the traditional owners of the land on which we meet today. I'd like to pay my respects to elders past and present. So we have a webinar today presented by Associate Professor Melissa Kang from the University of Technology in Sydney. And as I mentioned, presenting on the physical health of young people with a mental illness. I'm your moderator today. My name is Caroline Selenjak and I'm the National Projects Manager at Orygen, the National Centre for Excellence in Youth Mental Health. So welcome to this webinar. It's our first webinar on this theme of physical and sexual health in young people and its relationship to mental health. So thanks for joining me today to think about and talk about this great topic. So I guess just to introduce, it's my pleasure to introduce Associate Professor Melissa Kang, who is with the Australian Research Centre for Public and Population Health Research at the University of Technology, Sydney. She's also a general practitioner who's worked as a primary care clinician with homeless young people in Western Sydney for the past 20 years. Her research interests include sexual health and sexuality, access to and models of healthcare for young people and health system navigation for marginalised young people. She's currently leading the New South Wales Health-funded Access 3 research project in partnership with the Sydney University, where she's a clinical associate professor in the Department of General Practice at Westmead. So it's my pleasure to hand over to Melissa now to present what I think will be a very interesting and wonderful webinar for us. Thanks, Melissa.
Look, thanks everybody for joining me as we talk about physical health of young people with a mental illness. And it's interesting because even though I'm going to be reviewing some of the, the main kind of comorbidities, I suppose, of mental health and physical health and the health risks that some mental illnesses seem to lead to in later life for young people who are diagnosed with particularly serious mental illness during adolescence. I also actually want to talk about approaching any young person that we see in a really holistic way, because I think that there's a bit of an artificialness about separating physical from mental health and indeed from psychosocial and cultural factors as well. So really what I want to do is start by making a very strong statement about my philosophical position when it comes to caring for young people's health. I think that as we become more and more super specialised, we tend to, as clinicians, forget the whole person a lot of the time. And we tend to forget that the whole person is much more than just the sum of their physical, mental, sexual health parts. I think for decades, certainly when I was a junior resident and a medical student, we tended to have physicians sort of ignore mental health issues, and mental health specialists long advocated for physicians to consider psychological factors when assessing clients and to become much more skilled at detecting mental health symptoms early. But in my more recent experience as a primary care physician especially, I think that mental health specialists, as it becomes more and more specialised, I suppose, and the field advances, I suppose I feel that sometimes mental health specialists can be just as guilty and they tend to forget about physical health. And I think that all of us at times fail to recognise the impact and the importance of psychosocial, environmental and cultural factors and the determinants of health and disease, be that mental or physical health. So what I'm going to do to start with is talk about the associations between mental illness and cardiovascular risk, which is an important and emerging area of research. But I'm going to talk about the whole youth population, and most of this is Australian data. Mental health problems in young people are so prevalent that it would be wrong to think that they only have specific types of physical health problems. And although there's emerging evidence of association between some mental illnesses and cardiovascular risk in adults, and there's increasing interest in detecting these risk factors during adolescence, there are in fact plenty of other physical health issues that may or may not be related to a young person's mental health conditions, and they shouldn't be ignored either. So in other words, when we're seeing a young person with a mental health problem, or we're working them up to try and give a broad mental health assessment, we really shouldn't forget that there are a whole range of other physical health issues that occur in adolescence and early adulthood that may or may not be related to their mental health, but it would be wrong to ignore that. So my next 5 slides are full of data, and they're really just a snapshot taken from the most recent Australian Institute of Health and Welfare report, which was published in 2016. And the data itself comes from a range of different surveys that have been conducted over the preceding 2 to 3 years. So the National Health Survey, which is conducted by the Australian Bureau of Statistics, is a national household survey of Australian residents who live in private dwellings. The data on this slide pertains to those aged 15 to 24 years, and the denominator there is about 3.1 million young people. So in 2014 to 15, 22% of this age group were overweight and 15% obese. And you can see there what the body mass index cutoffs are for making those definitions. Being aware, of course, that before an adolescent is fully grown, their body mass index needs to be lower than it is for a fully grown adult in order to qualify for being overweight or obese. Just over half of these young adults were sufficiently active in the previous week, and only 3.3% of young people ate enough fruit and vegetables as per the NHMRC dietary guidelines. And that's, of course, 2 serves of fruit for young adults, or 3 serves of fruit, in fact, for 15 to 17-year-olds, and 5 serves of vegetables a day, or 4 serves for 15 to 17-year-olds. Looking at the mortality database, the leading cause of death in young people is suicide, and that's 11 per 100,000. And there's a big there's a big gender difference too in terms of presentations to hospital for injury and self-harm. So females are 2.8 times more likely than males to be hospitalised for self-harm, but males are 2.2 times more likely to be hospitalised for transport accidents. Just looking then at some chronic physical health conditions, and these data come from the National Health Survey. Just over 1 in 10 young people are diagnosed with asthma, and the most common chronic conditions reported were allergic rhinitis, which is hay fever, and myopia, which is short-sightedness. The type 1 diabetes rates, which is one of the most prevalent chronic diseases in childhood and adolescence, hasn't really changed at all over the last 20 years. And the rate at the moment is about 16 per 100,000. Turning then to health risk behaviours, our national data comes from a range of sources. The National Household Drug Survey in 2013 found that 39% of young people drank alcohol at levels that put them at risk of harm. That is more than 4 standard drinks on one occasion, at least once a month. And that was actually a decrease over 12 years. And in fact, a further 27% of this cohort had never drunk alcohol. So that's a huge increase of 16% in the last 15 years. So the statistics on alcohol use in young people has actually improved over the last 10 to 15 years. Just over 1 in 10 of these young people were current daily smokers, and that rate has almost halved since 2001. And the majority now of young people, in fact 81%, have actually never smoked. In 2013, there was a quarter of young people who had used illicit drugs in the previous 12 months, and that's significantly less than in 2001 when it was 33%. Continuing with looking at health risk behaviours, there are surveys every 5 years of secondary high school students, and that's years 10 to 12, roughly the ages between 15 and 18. And that inquires about knowledge and about sexual practices, and the latest one also inquired about attitudes and experiences of sex education in schools. So the most recent one took place in 2013, and that was published a year later, and found that 43% of sexually active students, and that's only about half of the sample, reported always using condoms when they had sex in the previous year. When we look at sexually transmitted infections, I think it's very well known that chlamydia is not only the most frequently notified sexually transmitted infection in Australia, it's actually the most frequently notified disease of all in Australia, and mainly it affects young people. So that's 15 to 24-year-olds, and also the 25 to 29-year-old age group is it's very common amongst men in that age range as well. And as this group would certainly know, adolescence and early adulthood constitute the most likely period for the emergence of most mental health disorders. And conversely, mental health disorders are among the most prevalent health issues in this age group. The National Mental Health Survey found that among 16 to 24-year-olds, 26.4% met the criteria for a mental health disorder, and of those, anxiety was by far the most common. The more recent National Survey of Mental Health and Wellbeing among Children and Adolescents found that 14% had a mental health disorder in the last 12 months, and anxiety was the most common in that group, followed by attention deficit and hyperactivity disorder, that was 6.3%, and major depressive disorders. So what I've just shown you is really just a snapshot across the range of the most prevalent physical and mental health diagnoses, risk factors or risk behaviours that affect Australian young people. What I'm going to try to look at now is the association between the two. And there's a great deal of interest in this at present, especially the association between nutrition and physical activity in young people with mental health disorders. So these are seen as modifiable risk factors as well as interventions in themselves for some mental disorders. But it's the link with overweight and obesity, and in turn the association with the metabolic syndrome, that is a really important current area of research interest in young people. There are other important physical health issues that are known to be associated with mental health disorders, and they include oral health problems, sexual health problems, and the physical health problems associated with cigarette smoking, alcohol, and other drug use, and of course the physical effects of psychotropic or some psychotropic medications. Now, despite the evidence for the associations mentioned in the previous slide and the fact that these associations occur across the spectrum of mental disorders, physical health receives less attention from health professionals once a young person is actually diagnosed with a mental disorder. So that's a really interesting phenomenon, and something that I think primary care physicians and physicians are guilty of as well. The strongest evidence for physical health effects of mental disorders is for psychosis and depression, with less known about the physical health association between physical health and personality disorders. So if we start by looking at weight, and we all know that overweight and obesity are very prevalent health problems across the Australian population. But when we look at the epidemiological evidence that shows a correlation for young people between various mental illnesses and weight and physical activity, we see that young people are more likely to be overweight if they're depressed, and more likely to be sedentary or have low levels of physical activity if they have any mental illness. Apart from that evidence, what are the particular associations for young people with mental illness? If we look further down the timeline at cardiovascular risk, there does appear to be an association between mental illness and morbidity and mortality from cardiovascular disease. So this body of work has emerged really in about the last 15 years, and there's been more studied in adults and older people because they're much more likely to be affected by cardiovascular disease than young people. But there's a real, particularly in many centres around Australia, a real interest in this particular area and young people with mental illness. So premature death among people with mental illness that is not accounted for by suicide is largely attributable to cardiovascular disease. And the contributing factors there are thought to include the increased exposure to known risk factors such as smoking, obesity, and less physical activity. There's less active management of some of the other risk factors. So the metabolic factors that we know are linked to cardiovascular disease, such as glucose intolerance, dyslipidemia, which is cholesterol and triglycerides, and hypertension. There's also the adverse impacts of other intrinsic factors such as disturbed circadian rhythm and sleep, and some of the sympathetic and parasympathetic nervous system regulation issues, as well as there's an interest in chronic inflammation as a potential pathophysiologic pathway between mental illness and cardiovascular disease. And of course, as we know, there are the iatrogenic causes from some of the newer antipsychotics and the impact that they have on metabolism. So just to remind us, or in case you're not sure, what is the metabolic syndrome? It's now thought to be the major underlying pathophysiologic pathway to cardiovascular risk in people with mental illness. Metabolic syndrome is prevalent anyway across the Australian population, with estimates somewhere between 15 and 20% of people over 25 years. Not everyone who's overweight or obese has or will develop metabolic syndrome, but those with the metabolic syndrome are at increased risk for diabetes, cardiovascular disease and chronic kidney disease, and they do die from those. Now, metabolic syndrome is diagnosed on the basis of the 4 criteria that you can see there. So excessive abdominal weight, which is measured by waist circumference, impaired glucose metabolism, hypertension and dyslipidemia. The presence of abdominal obesity and 2 of the other factors is sufficient to diagnose metabolic syndrome. And what's important to know, which I think does facilitate better healthcare for young people, is that the requirement for fasting blood samples to test for glucose and lipids has been revised. And in fact, it's recommended that if you've got a patient there in front of you and they haven't been fasting, but they're willing to have a blood test then and there, that it's better to get a random sample than to make them have an overnight fast and return for a blood collection, in a few days' time. It's believed that this cluster of risk factors leads to insulin resistance in some individuals who may also have a genetic predisposition, as well as environmental exposure to risk factors such as low physical activity. A joint international task force agreed on the criteria for the diagnosis of metabolic syndrome in adults, which are shown in these 2 tables. And what's important is that there are ethnic differences in the cutoffs for abdominal obesity or waist circumference, and these are very important. As you can see, the thresholds for abdominal obesity for Europeans and North Americans is higher than for other ethnic groups, and that there are also some gender differences within those ethnic groups. It was the International Diabetes Federation that reached consensus a few years ago now on the cutoffs for children and adolescents, and they're basically identical to those of adults, except for the 10 to 16 year age group, where it's body mass index that's used instead of waist circumference for defining abdominal obesity. So when we look at some of these epidemiological studies, we can see that the metabolic syndrome is associated with people with bipolar disorder and schizophrenia, and those on antipsychotics compared with both drug-naive patients and also those on antidepressants. But these have mainly been adult studies. The association between major depression and metabolic syndrome seems to be mediated by overlapping pathophysiological mechanisms involving the hypothalamic pituitary adrenal axis, the autonomic nervous system, the immune and inflammatory system, and stress and peripheral hormones. So there's a lot going on there that researchers all over the place are still trying to map out. Looking then at research among adolescent populations, there are a couple of important cohort studies that demonstrate an association between depression in adolescent females and obesity and or the metabolic syndrome later in life. So Gay Senior and colleagues in a large British cohort study suggest that gender could be a moderating variable, since this association did not hold true for males. In Finland, a similar association was found for women and not men. And the researchers further suggest that the process linking depression and the metabolic syndrome goes in both directions and is potentially lifelong. And then our colleagues up here in Sydney, Liz Scott and others in 2 of the Sydney Headspace Centres, recently published data that they'd analysed from some patient samples. They looked at body mass index and metabolic markers in a cross-sectional sample of clients aged 12 to 30 who were diagnostically classified into one of 3 mental health groups. And those are the anxious depression group, the developmental psychotic group, and the mania fatigue group. Apart from significantly higher smoking rates in this cohort compared to the general population, the other measures, which were body mass index, glucose, blood pressure and lipids, were not more or less prevalent and nor associated with one mental health diagnostic group compared to any other. And by the way, all the references on these slides are listed at the back of the talk, so all the papers that I'm referring to you can find easily. If we look at psychosis and metabolic syndrome, there's very strong evidence for an association with, between the two, and some of this is attributable to medication, so it is iatrogenic. There are certainly strong associations between smoking, obesity and psychosis in all age groups, but these are evident even at first episode, which tends to occur in young people. So in summary, as far as metabolic syndrome is concerned, it is a prevalent condition in the general population and increasingly of concern in young people across the population. Those with psychosis are at higher risk, and those with other mental health disorders, particularly depression in females, may need to be monitored. It is clear that treatment for mental health disorders needs to include nutrition and physical activity interventions, and I think in some ways it's negligent if we don't address those as mental health professionals as well as physicians and generalists. Just wanted to very quickly touch on screening for people diagnosed with depression, be that mild, moderate or severe. And certainly the clinical guidelines have been around for a long time when we assess depression in children and young people. And the recommendations are that we need to exclude physical conditions that could either mimic depression or exacerbate some of its symptoms. So here's a list from the most recent BMJ best practice guidelines. And so generally if we diagnose depression in a young person, we need to exclude an infectious cause, iron deficiency by looking at their blood film. We need to exclude thyroid disease and other nutrient and vitamin deficiencies. The BMJ best practice guide also recommends doing a urine drug screen. I'm not sure that that's something that in general practice we would routinely do unless that was indicated in the history. Certainly not something we would do without the patient's consent. What I'm going to talk about now are some of the common physical health conditions in young people across the population, regardless of whether they have a mental illness, because I think it is important to be aware that mental illness is common, but so are a whole lot of other physical health conditions that may not be correlated with having a mental illness. They just simply could be coexistent. And I think it's really important as part of holistic healthcare just to have an awareness of the sorts of things that present commonly particularly to primary care. So in girls, the onset of their periods, or the menarche, is a late event in puberty. Periods can be irregular for up to 2 years while the hypothalamic pituitary ovarian axis matures. Dysmenorrhea, which is painful periods, and that often leads to school absenteeism or the inability to participate socially or in sport, can occur in up to 85% of adolescent girls and young women. Absent or very delayed periods, as well as very heavy periods that might lead to anemia, those are less common in this younger age group. Whereas irregular periods are prevalent and can be from the immature axis or from stress. It's also seen in disordered eating behaviour, in thyroid disease and in metabolic and weight-related issues that may in fact lead to or constitute the polycystic ovarian syndrome, which in itself is also related to the metabolic syndrome. So that needs to be discussed with young women who are obese and have risk factors for metabolic syndrome, regardless of their mental health diagnosis, because it does have implications for their fertility, although we also know that when young women who have polycystic ovarian syndrome lose weight, that their periods often return to normal. Acne is one of the most common conditions in adolescents, and it might be a feature of PCOS, of course, but it's very common in its own right. And in fact, it's thought to affect, about 90% or more of adolescents. males and females, and it's dependent as a condition on the circulating androgens that typically accompany puberty. The psychosocial and psychological impact of moderate or severe acne needs to be considered when assessing adolescents with acne who might really not be confident enough to bring this up. And I know that over the years I've seen many young people who have quite moderately bad acne on their face who don't actually mention it. They present for some other reason. And I think that's often due to self-consciousness, embarrassment, or rather than a lack of awareness. And I think it's up to us to raise that gently with them, because there could be some fairly significant psychosocial ramifications, and that could affect, in turn, their mental well-being. The need for contraception is a very significant issue for sexually active young women, and I think that with the ready availability of long-acting reversible contraceptives now, as well as the oral contraceptive pill, which has been around for a long time, and emergency contraception being available over the counter in pharmacies, it still disheartens me to continue to hear anecdotes from time to time about attitudinal barriers to access, and I'm going to talk about that a little bit later. And finally, I want to mention chronic disease and mental health. And I'm talking about chronic diseases such as congenital heart disease and cystic fibrosis, which is a genetic condition, type 1 diabetes and juvenile rheumatoid arthritis. So we estimate that somewhere between 10 and 20% of young people live with a chronic illness, a chronic physical illness. And that depends, of course, also on the definition that we use. A review of the psychiatric consequences of chronic disease found associations between depression and anxiety and a whole range of chronic diseases, which are listed there. Type 1 diabetes is known to have significant psychosocial consequences, but it's also linked to higher rates of depression, anxiety, and behavioural disorders. And finally, looking at oral health, I think it's often a very neglected part of physical health assessments. Certainly, I think we tend to assume that children and adolescents and young people will visit their dentist regularly and that will take care of their oral health. But I think we can't really make that assumption. There are a lot of cost barriers to dental care in Australia. People with severe mental illness certainly do have higher rates of tooth loss and dental pain, and obviously smoking and other substance use and poor nutrition contributes towards that. I'm going to now talk about sexual health, and partly as a precursor to next week's or the next webinar, which is on sexual health and mental health and the associations between the two. And because you'll be having a webinar on sexual health, I'm not going to cover sort of behavioural data or prevalence of STIs or anything like that, but I'm going to talk more generally about adolescent sexuality and sexual health. And I'm also going to share with you some insights I've had over the 23 years that I wrote for Dolly magazine, because I think that that's possibly just going to give you a slightly different look at how I understand sexual health when I talk to young people. And I guess I'm starting with some fairly bold statements which come from my own research and my own experience working with young people. And I just like to, I guess, share these ideas with you. So I see adolescence and sexuality very much as intertwined. Adolescence, of course, is the period of life when puberty occurs and sexual maturity occurs. And I don't think we can underestimate the significance of that. It's also when partnered sexual behaviour begins, almost universally. And I think that it would be wrong to sort of try and separate the physical, biological development from emotional, cognitive development that occurs during adolescence, and the enormous behavioural, social and cultural factors that impact on a young person's sense of sexual identity, relationships, and their own sort of physiological feelings that come from new experiences like sexual arousal. I think it's important always to remember that partnered sexual activity in the second decade of life is both natural and universal, but it remains highly contextualised and stigmatised. So there are many cultures, of course, where it's unacceptable to have premarital sex, so sexual activity occurs in the context of marriage, whereas in many countries, but certainly the progressive liberal Western democracies, premarital sex has long been seen as socially acceptable. But I still feel that, based on my own research and just talking to young people, that there is still a sense of taboo, particularly if you're young and female and sexually active. There is still some sort of attitudinal barrier when they seek help from a lot of health professionals in talking about sexual activity, particularly if it comes to looking at sexually transmitted infections and young people feeling bad or being made to feel bad if, for example, they don't always practice safe sex. When we think about sexual health in young people, it's really important to consider puberty, sexual function, the fact that they're entering a new kind of relationship with other people that they haven't had before. The importance still of gender-based power differences in their ability to negotiate safe sex, for example. Young people's rights to sexuality education, as well as contraception, pregnancy choices and healthcare. And finally, that I think we tend to try and medicalise sexuality and sexual behaviour. For example, when we talk to young people about STI prevention and using condoms, we tend to sort of diminish the experience or the things that they're interested in, which is not so much focusing on whether they're going to get an STI or condoms. They certainly get the message, but it's not the most important thing to them. And I hope to illustrate that for you now with some of the research that I've done based on my work with Dolly magazine. And the reason I want to share this with you is because I think it is quite unique data that isn't readily available anywhere else. And I think it really does help to hear young people's voices when we look at, when we really read the words that came from them unsolicited. So I'm going to share with you just a few slides that show you the questions and the emails that were sent to Dolly magazine over different periods of time for the 23 years that I worked for Dolly. In fact, most of this data is not so recent. I think the most recent emails I've got that I'm showing you now are about 10 years old by now. But I do have some fresh data from last year that I'm about to analyse. So in case you don't know, Dolly magazine was the first Australian teenage girls magazine in the country for many years, first and only one. It launched in 1970 and it was a monthly magazine until about 4 years ago when it went down to bi-monthly, and then at the end of last year the magazine itself actually folded. So it went the way of many print magazines now. But it was, in its heyday, it had about 500,000 circulation, readership rather. And it was, it was very widely read. And it always had a help column that was written by medical practitioners and psychologists and other health professionals. So it was never made up. And the letters that were sent were always genuine, so they were never made up either. Just going to show you a couple of slides that I think for me really capture the spirit of Adolescent. So these are letters mainly from girls. There's a couple from boys, but this is very old. This comes from about the mid-90s, this letter. And this was a very typical example of the early experiences of sexual arousal and pleasure. And there are a lot of letters over the last 23 years about masturbation. And the rest of these are emails. So I've copied and pasted the emails as they were written, which includes grammatical and spelling errors. I'm just going to pause and let you read them for yourselves. And then these next few slides are a content analysis that I did with some colleagues about 10 years ago now, where we actually looked at 1,000 emails. And I also analysed separately some questions that were sent to me when I did some talkback radio, so that included young men as well. So this is kind of a combined content analysis where we asked, well, what is it that young people want to know when we don't approach them as health professionals and say, tell me your sexual history or your medical history. If these are unsolicited questions, what is it that they actually want to know? So first of all, what sex is. So we're talking about younger adolescents here who may not have had much sexual experience, and they hear words and terminology around the playground, in the media, on TV. So lots of questions about what sex actually is. Always a lot of questions from males as well as females about whether they're sexually attractive. And even when they have had some sexual experiences, there seems to be an underlying anxiety about whether they are good sexual partners, capable of giving pleasure, attractive enough, satisfying enough for their partners. But they're also experiencing sexual arousal for the first time, really, and that can be quite distressing. It can be pleasurable as well, but it's often causes a lot of anxiety and leads to leads to a lot of concern about whether it's normal or not. They're also very keen to know about what we might loosely call sexual function. So what is it that their bodies are doing that they couldn't do before, and what is it that they're noticing in the physical appearance of their bodies. So there's a lot of preoccupation with genital size and shape for males and females, but also some of the physiological changes that occur for both females and males. But for females, the natural increase in vaginal secretions often causes a lot of distress. And boys are often concerned by what feel like uncontrollable erections sometimes, or genital size, things like that, lumps and bumps and pieces of skin, things that appear that they notice. They're also concerned about different sexual practices and what they are, how to do them, whether it's something that their partners might want, anxiety, nervousness about having sex, and whether it's going to be painful or not. And there's always questions about same-sex experiences and same-sex attractions. And I suppose the point that I've always wanted to make when I show these series of questions to any audience is that when it comes to contraception and sexually transmitted infections, which is what health professionals are preoccupied with, it's actually the least most common group of questions that young people ask. And I think that's just really important to keep in mind, that while it's certainly our duty and our job to educate young people about unwanted consequences of sexual activity, and as health professionals we can give them information and access to things like contraception and condoms that they might not get from somewhere else, it's not necessarily going to be the thing that they're most concerned about. And this is a kind of breakdown of the analyses. So with the 1,000 email analyses, and that was only girls, where I've got the arrow there, you can see that STIs and contraception were almost the least frequently asked questions. There were a lot more questions about sexual practices and what they were and how to do them, and whether they were normal or not. Similarly, when I analysed the 200 or so questions that were actually broadcast on talkback radio, STIs and contraception did figure a little bit more highly there, but they were still not, that there were many, many other sorts of questions that were much more popular. And this was a slightly older audience as well, so they're more likely to be having more regular sexual intercourse. So I just hope you don't mind me sharing that with you, but I think it's hopefully gives you a little bit of an insight into the minds of particularly young adolescent girls, but also slightly older adolescents ahead of your next seminar on sexual health. I wanted to try and sort of tie all this together a little bit by telling you a tiny bit about the Access 3 study that was mentioned as part of the introduction. And that's an important study that's currently underway. We have almost finished data collection. In fact, I think we have just finished data collection this week. It's a multifaceted study with 4 separate components, but essentially what we're looking at are the barriers and facilitators to healthcare and how young people use technology and digital technology to access healthcare and navigate the health system. But what we've done is also have a longitudinal component that has followed a group of 40 marginalised young people over 12 months, and we've had a really good follow-up rate with those. And those 5 marginalised groups include homeless young people, sexuality and or gender diverse young people, Aboriginal and Torres Strait Islander young people, those of refugee background, and rural and remote young people as well. So those 5 different groups, we've had between 5 and 8 participants from each of those groups, and we've followed them over 12 months and asked about how they get around from one health service to another. Because they were a self-selected subsample of very marginalised young people, we did find very, very high levels of psychological distress, much higher than the general population of the same age. So they did actually access a lot of healthcare and a lot of mental health care. And what we found in talking to them and also doing some quantitative research on the barriers and facilitators to care was that cost was the greatest barrier by far. So even though they might be able to visit a GP and be bulk billed, they might not necessarily be able to afford the medication that's prescribed. Or afford to go and see the psychiatrist or the medical specialist that they were referred to. And of course, we certainly had good feedback from some of these young people about their experiences at headspace centres, but the downside to that was that they needed more than the Medicare allowable number of sessions to feel like they were getting the care that they needed, and that then became a problem for them as well. And sometimes that discontinuity of care because of the way the cost structures work actually had a negative impact on their sense of well-being and support. We found that for just about all these groups of marginalised young people, there was a very strong sense of feeling judged and discrimination just for being young. Certainly there were some reports of things like racism and homophobic or transphobic sorts of attitudes. But as well as that, just the fact of being young was often seen as a reason to be judged for discrimination. So we heard some quite distressing stories, but we also heard some really positive things about their experiences with various health providers. So what I've done is really kind of walk us through a few different, I guess, aspects of physical health as well as my view on sexual health and sexuality in young people. And I guess in closing, I really wanted to just say that it's important for all of us, whatever our role is in the healthcare of a young person with mental health problems, to consider the whole person and their environment. I think that we do this in our heads and we think that, that is important, but sometimes in practice we possibly don't do enough, and this comes from the research on Access 3 and the stories that we're hearing from young people. I think also we've spent a long time and invested well in training health professionals about psychosocial assessment, or the HEADS assessment, and it is an extremely useful tool, not just for assessing risk and protective factors, but for rapport building and engagement, and giving particularly GPs, I think, a good framework to work with when they're first getting to know a young person. But I think sometimes we actually forget to do a physical health assessment once we get caught up in mental health problems. The other thing I wanted to hope that I highlighted is not to assume that it's easy for young people to get from one health provider to another, and that all of us can help, I think, with navigation around the health system and ensure that there are clear communication lines with other health providers. So, for example, the young person goes to school and their mental health problems are impacting on their study or their ability to attend school, or perhaps it's because of a physical health problem, or perhaps it's because of bullying. I think it's worth spending time talking to the young person about how we can work with the school, with their permission and with their knowledge, to improve the situation for them. So I know that as a GP that I often write reports, medical reports for schools, for special consideration, or I might write letters of support for housing, or for juvenile justice, all sorts of advocacy, I suppose. But the other thing that I think we need to do is to really look at the barriers of cost and help young people get the medication that they can afford. Consider what it is we're prescribing. Consider the, how that will pan out over time. So another example, which may or may not be related to mental health specifically, but is something like as simple as the oral contraceptive pill. And there's, I think if a young woman has acne as well, there's a tendency to rush to prescribe the newer oral contraceptive pills that have the newer progesterones in them because they're thought to be superior for treating acne. But in fact, they may not be affordable. And then the young woman loses her contraception as well as her acne treatment. And I think it's really important to let them know how much something's going to cost, or even make the phone call for them if they don't want to do that themselves, and just rethink what it is we're prescribing, as well as when we make referrals, to look into the cost and to advocate on behalf of young people for more affordable services if that's going to be a barrier for them. So, finally inquiring with them what some of those barriers and facilitators to care might be. So if, as I said, cost appears to be one of the main ones, but it could be something quite simple like just the days of the week that a certain provider works, or their availability after school, things like that. Obviously, gender of the provider might be important for some people. It could be that they might be concerned that the providers from a small minority community that they're from. So all sorts of things like that. It's worth actually asking about, because I think often we hear stories that they've been given a referral, sent off to make the appointment themselves, and they've just found it too hard. But they didn't want to say anything to us, the referrers. So I always like to have a conversation with the young person when I'm going to make a referral about that process and what's involved, and see if there's any help that they need from me or one of my colleagues. So look, that's all that I was going to talk about, but I'm very happy to take any questions or see if anyone has any comments or would like to share some of your experiences.
Thank you so much for such an interesting and informative presentation. We do have a couple of questions. I'm just thinking, just wondering whether, does it say show my screen? So just before we launch into questions and answers with Melissa, I just wanted to remind people that we do have workshops available through Orygen as well, and not only in Melbourne but also in various cities around Australia. So check out our national training calendar. If there's something that you're interested in, please do get in touch with us and enrol, and if there is something that you're perhaps interested in that's not particularly there, you can still get in touch with us, and we can deliver different workshops at your organisation or at your workplace as well. So that's just a little reminder in there for people who are interested in that. One of the questions that I did have for you, Melissa, was, and this is probably a question that you get asked a lot, is whether there are any good websites or resources, particularly around sexual health, for young people. I guess people are looking for, you know, the kind of go-to, I guess, a little bit like the Dolly Doctor advice that we're giving out for many years. But whether or not you know of any good, perhaps online resources for young people around sexual health.
There are many, and you know, some of them are a bit out of date, I suppose, or haven't been kept up with. But the ones I could certainly vouch for, I guess. They tend to have the medical information, but they are very accessible for young people. So there's, I think, all the family planning websites in all the jurisdictions. I'm certainly most familiar with the New South Wales one, but I know South Australia and Victoria, and I think ACT as well, have really good websites, and they have sections for young people. The family planning in New South Wales one has really has a section for young people. It has really easy to read fact sheets. It's got them available in multiple languages. That's mainly, I guess, talking about contraception, a little bit about sexually transmitted infections. Then there's the, again, it's New South Wales. It's called Play Safe, and it was designed with and for young people especially, although it's available there for anybody. And that, of course, does focus on STIs particularly, but it does have something called the Nurse Netty section, where you can actually ask like a Dolly Doctor type question. I think that happens with a bit of time delay. It's a question and answer. They used to sometimes have live forums. I'm not sure if they still do, but they are, again, like Dolly Doctor, they are real questions that get sent in and they get answered by real health professionals. So that can include all sorts of things that aren't STI related. In fact, I think I was asked to answer some once on puberty. So it was obviously written by quite some young people, younger adolescents. Actually, the Reach Out website, which was one of the very first youth mental health promotion websites in the country, if not the first one, that's really quite broad now and quite diverse, and has a whole section on not just sexual health but relationships, sexual orientation, sexual attraction. So I find that really a very comprehensive website that is always kept up to date. And it's also got some just generic information on it about how to access healthcare, what's involved. So that's Reach Out. And then there are some specific websites for sexuality diverse and gender diverse young people. I'm trying to think if I can name any of them off the top of my head. Minus 18. Possibly Somazone, but what I can do is find all these links and send them to you. But,
that'd be great.
Yeah.
Fantastic.
No problem.
A couple of other questions. So one is quite specific. So asking about whether the studies comparing weight in young people with mental illness to those without mental illness, whether those studies control for other factors such as socioeconomic and status and unemployment.
Apparently, yeah. Apparently so, yes. Okay. So it was thought to be an independent association accounting for those other confounding variables, yes. But there's not probably quite enough yet that has looked at young people and followed them over time. And also I think because there's this seems to be this emerging pattern of a reciprocal relationship between particularly depression and those metabolic syndrome risk factors, that there just needs to be, and it's ongoing now. I'm aware of some colleagues up here in Sydney who are working with the Brain Mind Centre at Sydney University, looking at hormones as well as metabolic and inflammatory markers. But I think we're waiting to see what shows there.
Yeah. And I'm aware of the time, but we've probably got just time for one last question.
Sure.
So this person said to me, they appreciate the input of young people in your talk, and it's vital to hear their voice. So what do you think creates the barriers for clinicians in terms of, I guess, asking about physical health and checking around physical health, and how can clinicians overcome their own barriers in asking about and hearing the kind of issues that young people are dealing with?
I think part of, yeah. Look, I think there's a few when it comes to physical health and mental health. I think part of it's just because we see ourselves having certain roles and certain specialist knowledge, I suppose, and we think, oh well, it's not for me to ask these questions because I'm not an expert in that. And I'm not suggesting that we are all experts in everything. I don't think that that's realistic. But I think what we can do is to certainly find out, so if we're a specialist of some sort, asking the young person if they have a GP. And a lot of them don't, or a lot of them don't have a regular GP. A lot of them will visit a GP that's convenient and available at the time. So they don't have that continuity of care. And that's one of the issues actually in the primary healthcare system that we're exploring in the Access 3 project. So I think we can always try and encourage young people to try and identify a GP that, or a practice at least, that they will go to consistently, and sometimes even help them to do that. If they do have a GP, or if they sort of start to engage with a particular practice, I think then if we're not a GP ourselves, we can, over time and as it becomes appropriate, is actually ask the young person if we could contact that GP. I like to do that a lot. When I work as a GP in the public sector, but a lot of the clients I see are either seeing psychologists in Headspace or in our local mental health service, or the adult mental health service. And I always ask the young person for permission to make contact with the other professionals and actually have a conversation with them, so that we're kind of all working towards the same goal, I guess, which is to, give the best healthcare that there is. So I think we sometimes need to just overcome our own busyness and our own perhaps hesitation to try and, it's, I guess, a virtual case conferencing or team approach is what I think is important. So I think, if we're a mental health specialist, we don't have to necessarily ask about physical health conditions. We could broadly ask, but more about sort of making sure that all the right players are in the game, and that the young person knows how to access the various professionals that they might need. Sexual health is a whole other ballgame, and that might be talked about next time, but I think there's a lot of barriers to any health professionals talking to young people about sex, which are, there needs to be a lot more work, professional development to make people more comfortable to do that, because young people absolutely don't mind talking about sex if they feel, that you're comfortable with it. They're generally very happy to open up about it and often quite relieved.
Yeah. Well, hopefully we'll be able to touch on a few of those issues as well at the next webinar. But thank you very, very much for your time today. It's been really interesting, and hopefully all of our audience has gotten as much out of it as I have. So again, thank you for your time, and it's been a real pleasure.
Thank you. Thanks very much.
That's great. Just before people head off, I'll just remind again that we are having another webinar in a few weeks' time. So we have Dr. Brian O'Donoghue presenting on sexual health and youth mental health. And then a few weeks later we have a series of webinars, I guess, on sexual health and youth mental health, one focusing on, I guess, on interventions and case studies, and hopefully we'll be able to, I guess, unpack some of those questions around how to talk about sexual health and sexuality with young people in a little bit more detail. So please register by visiting the Orygen webpage for those 2 webinars, and of course they are free as well. So thank you very much everyone for your attendance. We hope you found it interesting. Again, you can watch this anytime by visiting the webpage, and you will get an email letting you know when the webinar is available for download. So thanks very much, and we'll see you again soon.